Thank you for having me. I'm going to talk about moving beyond the Affordable Care Act, a little bit. Mostly going to talk about the economics of healthcare and the logic of single payer and the possibilities of enacting a single payer plan in the state of Missouri and the economic benefits you would have. And along the way, I'm going to spend much of my time doing my favorite thing, which is dumping on the economics profession. So those economists in the audience will please forgive me. And I say I do this as a proud economist, and I've been an economist basically my entire life. When I was a little kid, I used to read these Brookings papers. I was a total nerd, But that said, I've learned along the way that the economics profession is boring. My kids tell me this. My spouse tells me this. It's like, okay, Debbie, thank you. But we do have some jokes. We have 3. And one of them's even funny. Maybe I'll tell you that one along the way. But let me just say about how boring the economics profession is, that students periodically, I teach these mega lectures, 8 in the morning, Mondays and Wednesdays, 650 students in the class. I give out chocolate, which if you Google me, apparently that's what you learn about me. I give out chocolate in my classes, and I bring my dog. But anyway, about every 2 years, one of these students, so talking about 1,000 students, every 2 years, one of them will write to me that they heard a joke. And it's always the same joke. The one about the engineer, the physicist, and the economist on a desert island. If you don't know the joke, well, talk to me afterwards. But that tells you how bad it is. We've got one joke, and it keeps going around and around. I heard that joke as an undergraduate. Go to graduate school, I hear the joke. It's like, okay. So we have a terrible sense of humor. We also always say the same bloody thing, use markets. And if there's a problem in the world, it's because we don't use markets enough. We haven't commoditized everything. If only we used markets more, our healthcare problems would be gone. What's the problem with healthcare? Rapidly rising costs? Well, that's because on the margin, people are not paying for the cost of their healthcare. It's covered by insurance. So the solution is to co-pay, cost sharing. Have people pay for going to the doctor on the margin. In essence, do away with the insurance function. Now, just to kind of make the point here that I know a little bit what I'm talking about. I studied, general equilibrium from Ken Arrow, whose article on health economics in '66 at the AER is kind of the founding thing. It's one of those wonderful articles that's a classic in the Mark Twain sense that everybody cites it and nobody reads it. You read the article, he doesn't say to use markets. Where did this stuff come from? It comes from this is what economists do in the United States now. When they talk theory, maybe at a graduate level, you may get somebody talking about all the problems with markets, whatever. But when they come to actual applications, it's always markets. Charge people for what they do. If you have insurance for shoes, you'll get lots and lots of shoes. Bad thing. If you have insurance for healthcare, you'll consume lots and lots of healthcare. Notice, economists slide over. You're not a patient when you get healthcare. You are a consumer of healthcare. And you're consuming too much. And as I say, if you listen to economists, the joke's on you. This is what the economics profession has done for healthcare. Co-pays, deductibles, high deductible plans, multiple plans, which, just to kind of peek ahead, what we've done is we've created a massive administrative bloat in the healthcare sector. We are driving up the cost of healthcare in order to reduce people's access. That's the goal, because you're using it too much. Behind this is another theory. I studied from Arrow. I also studied from Richard Zeckhauser at the Kennedy School. And Zeckhauser sat in a room, smaller than this. It was actually a very small room. There were 6 or 7 of us at the seminar. He sat there, looked people straight in the eye, and said, the health care spending we do in this country is all consumption. It's a waste in terms of improving people's health care. The medical profession has done nothing in 100 years to contribute to life expectancy. Keep that in mind. If that's your attitude towards health care, then of course it's like shoes, a consumption good. It's like coffee. My father was in the coffee business. Drink too much coffee? That's a waste. Why would you drink too much coffee? Because you're not paying the proper price for coffee. Same for healthcare. You're consuming too much healthcare because you're not paying the price. And there's no social benefit to it because going to the doctor is a waste. Okay, we're going to talk more about Zeckhauser here. I'm different. I was the last, those of you who know the history of Harvard economics. Harvard in the 70s fired a bunch of its people, kind of Sam Bowles, Herb Gintis, Rick Edwards. The left end of the department, they moved out to UMass Amherst, took over there. I followed, as a graduate student, I followed along. I was the last of the Harvard radicals. I turned the lights out on the radical study group when I left. And we don't look upon healthcare as like shoes. If you're interested, then we can talk about UMass economics. Okay, where we're going, problems of U.S. healthcare finance. Waste is not an accident, but is inherent in the system that we have. Inherent, I say here, in private for-profit healthcare, but it's really inherent in commoditizing healthcare, in treating healthcare like a commodity. Solution, single payer. I talk about financing and distributional effects, and the effect on jobs. Okay, here's what you've got in Missouri. Estimates for January 2015. One reason I put this up is because people think that healthcare in the United States is a private activity. You get your healthcare through your employment, or you buy your health insurance policy, it's not like other countries where it's all public. Well, actually, no. More than half the financing of healthcare in the United States, it's about 50-50 between public and private. And it shows up here, about half the population of Missouri gets health insurance through their job or through their spouse's job or their parents' job. Another 350,000 buy private individual insurance plans. 118,000 estimated, this is from the Congressional Budget Office, and you guys seem to be about on track, actually. 118,000 will get insured this year through the marketplace exchanges set up under the Affordable Care Act. 800,000 Medicaid, 800,000 Medicaid, which could be a lot more, but it's not going to be, at least at this point, unless people listen to Ed. 900,000 through Medicare. 46,000 through various other S-chip and other things. And 700,000 will be without insurance as of January 1st. This half is, or over half is private, the private market. This, which including the Obama exchanges, these are heavily subsidized. These people are, 40% are covered through the public sector. These people, especially the Medicare people, are more expensive than the rest. They're older, which is the major determinant of how much your health care you're going to use, is how old you are. Sorry, I'm reaching that age where I start thinking about that. So this is half or a little more than half the spending in the state. Okay, this is what's been going on nationally. I go back to 1971 because those who are into these things will remember two major events in 1971 regarding healthcare in North America. The first is President Nixon, may he blah, 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 but he proposed a national healthcare plan. It was a reinsurance plan, basically a catastrophic coverage to be funded through the public sector. The plan was, and this actually was kind of talked out, people were talking between Senator Kennedy's office and the president's office, that after the election of '72, one of the worst days of my life, Nixon would be inaugurated again, and then they were going to one of the major initiatives that Nixon planned for his second term was National Health Plan. Not the type of health plan that Ted Kennedy wanted or that I wanted, but something, at least cover catastrophes. It was kind of interesting, but that's '71, that's Nixon's plan. Part of also built into Nixon's plan was he was going to trade off The Democrats would get catastrophic coverage, and they would give on HMOs, health maintenance organizations, and other capitation plans for Medicare that would restrict access. That was Richard Zeckhauser, by the way. He was involved in this planning. Okay, that's 71 in the United States. Canada, at the same time, remember, I don't know if you guys know about this, but there's a country north of the United States. We know about it in Massachusetts because, it's kind of like we're closer. And we get their weather, which makes us pissed as all hell. We sometimes get their radio stations and things, but, okay. So anyway, it's called Canada. It's not a state. And in 71, they established a national plan administered on the provincial level for single-payer health plan. Each province has its own plan. They differ a little bit, but the basic gist is the same. It goes back to Tommy Douglas, who was the socialist prime minister of the province of Saskatchewan. Tommy Douglas voted the most beloved Canadian of the 20th century by the Canadians, not by us. And the grandfather of Kiefer, shoot them in 24 hours, Sutherland. Really? Yeah. Kiefer Sutherland is not a U.S. citizen. He saves us all, well, not anymore, but he used to save us all the time from the bad guys, but nope, he's Canadian. Okay, anyway, back in 71, we were comparable healthcare spending, the United States and Canada. Okay, we spent a little more than they did, but it's kind of within the ballpark, within well less than one, order of magnitude. And life expectancy was comparable. The Canadians a little more than us, but not all that much. Since then, the United States, this is our healthcare spending compared to a base of 100% in 1970. It's gone up 36, 38-fold. That's nominal dollars, not real dollars, no cost of living built in there or anything. Compared, this is Social Security average wages. Gone up less than tenfold. Yeah. Which is actually, as an economic historian, kind of interesting to me that you cannot find a period of 40 years in American history without a rise in real wages. Basically, you want to know what prices were like? What price changes have been? About the same. Real wages have been about flat. No period in American history of more than a decade without rising wages, before the 1970s. We're in a new era. If you're interested, you should check my blog piece on Who's Recovery, which came out last week or the week before. Anyway, that's what's happened is a growing burden of excess healthcare costs. People have to dig into their pockets to find the money to pay for healthcare, pay for their insurance premiums, pay for their co-pays. Their employers are saying, we're not going to give you a raise because we're spending all this extra money on employer-based health insurance. What aren't you doing because you're spending this money on healthcare? You're not getting that extra boat. You're not taking the extra vacation. You're not paying for your kids' college. Your kids have to take out college loans. There's all sorts of stuff that ripples through the U.S. economy because we're spending so much on healthcare. This is Missouri. I only went back to 1991. Makes the same point. Here's average, this is per capita income in the state. This is the recession of 2007-8. Excess health burden. People in Missouri are digging down deep to find the money to pay for rising healthcare costs. The burden is especially on the poor and the working class. What else would you expect? Healthcare is basically financed in the United States through insurance premiums, which are a fixed amount that do not depend on income. Doctors will adjust their fee schedule. Sometimes you go and you say, I can't afford it. I'll give me $20 instead of 30. But once you're in insurance, it's basically a fixed copay. So basically, it's a fixed amount of money. You go to the CVS or the drugstore, you tell them, I don't have to, well, it's like, this is what the drug costs, regardless of your income. So the lower you are on the income scale, the heavier the burden. Plus, where are the sick people, the disabled? I mean, they're kind of scattered throughout, but they're especially down here. Because if you're sick and disabled, you don't earn as much You don't work as many hours, you don't get paid as much. So the sick are concentrated down here, and the money is concentrated up here. You may see, this is the top 400. It's it's just extraneous to this graph. I mean, the point would have been made with just the top 1%. But the top 400 is, I'll admit to you guys, I'm not sure it's safe to say it in the state of Missouri, but I have an Obama-Biden t-shirt. I have an Obama coffee mug. I have friends in the Obama administration, even if they wouldn't want to admit it in public. People I went to graduate school with, people I work with, whatever. But they put out, a couple years ago, the IRS put out a summary of the top 400 tax returns in the United States. It's a wonderful document because it gives the averages for these compared to the averages of everybody else over the last 20 years. So you can track how much more these guys are making. How much more compared to the rest of us, but how much more they're making than in 1991. Pretty steady growth in their relative income. It has the sources of income and it has the taxes. Their taxes have gone down. Our taxes have gone up. It's just a wonderful thing. I mean, even compare, these are 400. The rest includes these guys. Anyway, so we have the income of these. These are like $170 million this year per person, per household. I wish I had $170 million. Okay, anyway, if you want just one graph, this is a good candidate. The next one is an even better candidate. This gives how much we're spending on healthcare. You've all seen graphs like this. This is from the OECD, which we used to call the Club of the Rich, rich countries. It goes back to the Marshall Plan, in case you didn't know that. Yeah, I do like to show off. But anyway, the OECD, for political reasons, added all sorts of other countries that just don't belong and mess with the data. I usually try to remove them, but I didn't in this case. Turkey, Mexico, Poland, Estonia, Chile, the Slovak Republic. I mean, these countries don't belong here. They're really different. But okay, compare the United States with countries that are comparable. France, which the World Health Organization a couple years ago said had the best healthcare in the world, we spent more than twice as much. I was like, compared to anybody, we're spending vastly more. And we're not getting our money's worth. Two things from this graph, which is my all-time, well, actually it's my second favorite. My favorite graph is kind of too complicated to use in these cases, but if you want, I'll send it to you. Okay, this is Zeckhaus's wrong. Healthcare spending per capita versus life expectancy. There's a relationship. Not only a relationship, it's a strong relationship. This is the OECD member nations. The R squared is 0.72. Half the variation in life expectancy is explained by how much you're spending. Spend more, you live longer. Why is this a surprise? Why would anybody think of going to the doctor as a consumption activity? That you do for the fun of it. I like my family doctor. We socialized together. We taught his kids at Hebrew school. I trust him. But when I go to his office, his magazines are boring, and it's like, I don't do it for fun. I see him professionally because I feel sick. And then he sometimes does something that helps. I don't think I've ever been in a life-threatening situation, but when I broke my shoulder, it was good he treated me, and there are things that happen. And those things do add up over the course of a lifetime. Less morbidity is associated with longer life expectancy. Treat people when they get sick. Okay, I would have gotten better anyway, but if it's treated, then the chances are less that I'll get something worse, and good that it will, promote my general long-term health. So Switzerland is right on the line. They spend, on this measure, they spend about the same as the United States. They live 4 years longer. If we were on the line, we would live 4 years longer. Given our spending, we would have 4 more years of life if we were like everybody else. Or, given our life expectancy, we could spend $7,000 less. If we were on the line, we could reach the same life expectancy, $7,000 less. I don't like to ask this, but think about it. Which would you choose? I'm old enough that you know which one I'll go for. You know, college students in the audience and people with, people thinking about their student loans might choose differently, especially if it's about me, rather than you. I mean, you could reasonably figure that by the time it matters for you, life expectancy will be much, much more anyway, so it's like, why bother? Okay. Here's healthcare spending in the United States compared to the rest. I got rid of the countries that don't belong. So for the affluent OECD members, this tracks their healthcare spending. Back to the 1970s, we were like 1.5 percentage points above of GDP, gross domestic product, above everybody else. Now we are almost double everybody else. How much is this? The difference between 18% of our gross domestic product and 10%, 8 points of gross domestic product, comes to $1.5 trillion. Remember Everett Dirksen saying a billion here, a billion there? You're talking about real money? Well, think about a trillion. $1.5 trillion, country of 300 million people, $5,000 per person. Take that and apply it to your student loan. $5,000 more per person on healthcare in the United States than in the average of the OECD. It would be fine if we were getting fabulous healthcare, but as you remember from this one, we're not. And over here, you see what's been happening, and you see how it's been getting worse. Yeah, because, as I say, we listen too much to the economists, or the other economists. Had a medical problem, did not visit doctor or clinic. This is survey data by the Commonwealth Foundation. 2001, almost 14%, over 14% of Americans had a medical problem but did not go to a doctor. That goes up. By 2010, we got that over 25%. Yeah, we're pushing it up. Great. More people don't get to go to the doctor who need it because it's expensive. Do not fill a prescription. This is my favorite because here, this one is your subjective judgment about whether you need to go to a doctor. And maybe you shouldn't go to the doctor. Maybe, you're overdoing it. Maybe you should just lie down. We could, get into a discussion about that. But this one, a doctor gave you a prescription. So you saw a doctor. The doctor says you're sick. Take this. You've got this problem. Take that. And it's not just antibiotics for sinus infections. There are people who don't take their diabetes. They don't take clearly essential medication because it's too expensive. Or sometimes worse, they stretch it out. And then they end up back in the emergency room or something. And the doctor says to them, "How come you didn't take your medication? Didn't I tell you? I told you to take it, but I didn't tell you how you were going to pay for it." So 25% of Americans don't fill prescriptions. Skipped recommended tests from 10%, we're up to 25%, did not get needed specialist care. It's kind of interesting, this one has not gone up as much as the others, but it has gone up. Overall, any of these cost-related access problems, we had over 28% in 2001, and now we've pushed that number to over 40%. Close to, over 40% of Americans did not have some access, needed it but didn't have it because they had cost issues. They couldn't make the co-pays. They couldn't do the cost sharing. It's especially a problem for those without insurance. Like, surprise, surprise, surprise. Insurance makes a difference. This is why I strongly support the Affordable Care Act. I had this experience in Massachusetts when we got Romney Care there, which is basically ACA light, or ACA in one state. And I was like, I want single payer. And I even, said to people, this is going to suck all the money out of education, and we shouldn't be putting all this money into the insurance industry. Well, shortly after the Romney Care went in, I was at the hardware store, and these two women behind the counter, you can imagine minimum wage or a little above, were talking, and one of them said how she got on insurance through the Massachusetts Connector, which has, just like the exchanges, heavily subsidized, et cetera. And she was able to take her son to the doctor for the first time in 3 years or something. And I wanted to cry that it's working. We institute a social policy and it's helping somebody. You know, it's like, okay, maybe her son didn't need to go to the doctor, they could have gone to him, but kids need to go to the doctor periodically, you know. So I was so happy, and ever since then, this is what you get. Over 60% of people without insurance had an access problem. They needed it to go to a doctor, they couldn't afford it, they got a prescription, you know, something like that, down to 28%. So the ACA, to the extent that it reduces uninsurance, will have this effect. Lots of people will be able to have access who do not have access. But notice, the proportion of Americans insured all year round who had an access problem is greater than in any other country. Even for those with insurance, there are access problems. More in the United States than anywhere else. I mean, in the UK, 3% of people who needed to see a doctor had problems getting there because of access. Okay, if it's quick. Yeah.
Well, I was just wondering, do you know why people with insurance were having problems with that?
Because, well, we'll get to this. The average deductible in Missouri now for a private insurance plan is almost $2,000. You have insurance, but it doesn't cover anything until you spend $2,000 out of pocket. You have co-pays. My wife was cleaning out her pocketbook, which is kind of scary for a guy to watch. This is 2 years ago, and she lined up her old health insurance cards, you know, which immediately got me thinking about why do they send us a new card every year? We've had the same insurance for over 20 years. Why do we get a new card every year? And right away, she told me why. She said to me, Jerry, do you realize what's happened to our copay? It's gone from $10 to $35 for a simple office visit. You know, and next time one of us was feeling bad, you know, and I suggested, oh, maybe you should go to the doctor, or maybe I should go to the doctor, I don't remember which. She, the wife of a full professor earning a decent living, said, oh, is it worth it, $35 copay, maybe we shouldn't bother. You know, I mean, it's like, that's a tiny scale. But there are people, you know, if you get out of college, you have a minimum wage job as a barista at the local Starbucks, and you're looking at a $35 copay or a $40 copay or a deductible. You think about it. You have insurance, but it doesn't cover what you need. Especially for the poor. 52% of Americans with below average income experience some form of health care access difficulty. Even for Americans with above average income, more have access difficulty than in any other country. Yeah. This is a result of our campaign to control healthcare costs by restricting access. And it's been completely misguided because it's not getting at what really is going up in cost. Why are costs rising for healthcare? Why are they rising so fast in the United States compared to elsewhere? Because of drug prices and administrative costs. Those are the cost drivers. It's not that, I mean, doctors are becoming more expensive, but so is everything becoming more expensive. You know, hospitals are going up in price. A lot of these are because of the administrative costs of interacting with the health insurance industry. The big drivers are administrative costs and drug prices. Administrative bloat in the US healthcare system. Just the insurance companies alone are $200 billion of administrative costs. Employers, another $30 billion that they spend choosing insurance plans. And I have friends who have small businesses around Amherst, and they hate this. First of all, because every year the prices are going up. They have to explain to their workers why the costs are going up. And they have to choose a plan that basically means choosing among their workers. Should I get a plan that's going to be good for John, whose wife is a cancer survivor? Or should I choose a plan that's good for Ted, who just graduated college, is healthy, you know, and just worries about getting hit by a car. Otherwise, doesn't have any issues. You know. U.S. doctors spend 4 times as much interacting with the insurance sector as do doctors in Ontario, Canada, with single payer. Healthcare employment. What's the biggest occupation in healthcare? Administrative support. Most American hospitals have more people in their billing and insurance divisions than they have beds. More than 1 billing and insurance person per bed. You know, the first time I said that, you know, I said, what on earth are they doing? And since then, many people have told me, have you looked at a bill? Have you asked to have a printed out itemization of a hospital bill? That's what they do. You know, they work out these 20-page bills. You know, and then they talk to the insurance company about, you know, where you put different costs. You know, and every insurance company, every insurance plan, and Massachusetts, you know, okay, I'm a loyal citizen of the Commonwealth of Massachusetts. I think we're the best state in the country. We do everything as well as anybody, and that's arguable based on our students' test scores and this, that, whatever. But we have now 8 insurance companies, and each of them has dozens of different plans. You know, the Group Insurance Commission that I am in, we had 3 plans when I started at UMass. The plan for healthy young people, the plan for middle-aged people, and the plan for unhealthy old people and retirees. That's actually what the human resources person told me. So we bought the plan for healthy young people, which worked great until my wife got very sick. And then, we were sorry. But since then, we've switched to the plan for the retirees and unhealthy people. But even within that plan now, first of all, there were now at least 12 separate lines, and each of them has multitude of plans to offer. So in the Group Insurance Commission, we have probably like 50 different plans. Each of them has different prices for each activity, different doctors you can go to, different hospitals you can go to. Figuring all that out and applying it to any individual at a hospital takes all day. And that's why they have so many billing people. Yeah, I can say this here because we're at a campus. This, to me, the first time I saw it, reminded me of a graph in the Chronicle of Higher Education showing the number of administrators and number of faculty. Some of you remember that. But no, it's not that. It's administrators and physicians. Same thing. You know, number of physicians in the United States about doubled. You know, kind of kept up with population growth, but per capita physicians in the United States is less than per capita physicians in most other affluent OECD countries. Administrators, though, we are number 1. Nobody has anywhere near the number of administrators that we have. How much waste? There are different ways to look at it. If you just compare the United States with Canada, we spend about twice as much, so you'd say half of what we spend is waste, which, by the way, that's about the private share of U.S. health spending. So you could say it's all waste. Compared to the rest of OECD, the rest of the affluent OECD spends a little less than Canada, so you'd say more than half. You adjust this number for life expectancy, 75% of what we do is waste. You just say, okay, go back to 1971 and say we had increased our spending at the rate of Canada, which, by the way, is what Medicare has done, US Medicare. The Canadians call their plan Medicare also, just to tease us, because it's so much better than our Medicare. You know, I mean, when they were talking about bringing back the draft during the Iraq War, you know, I had a daughter who would have been eligible, except they don't draft women, you know, but maybe they would have. And my wife's like, we have to make plans in case this happens because we have to go to Canada. And I thought, well, at least I'll get Medicare. You know, you know, it's a long commute to Amherst, but you know, it's doable. You know, once a week. I had a colleague who was denied. I got to hurry up. Okay, excess U.S. spending growth, 60%. You know, it's like, however you cut it, these are huge numbers. I mean, the lowest number here, 37%. That's about $1 trillion. So it's no accident. This is not one of those things where, you know, you tripped and you fell. We've got this administrative bloat because it's policy. It's the policy of the insurance companies. Abetted by, I don't want to dump on Zeckhauser, who's a nice guy, but abetted by economists like Zeckhauser recommending that we control healthcare costs by restricting access, making people pay on the margin for what they get. The problem is the 70-10 rule, and this applies globally. Half the people in the United States basically did not see a doctor last year. They had no health care costs. A quarter of the people on Medicare did not file a claim. 70% of your costs go to 10% of your people. You fall down, I hurt my fingers the day after the election in 2012, running with the dog. I tripped, fell, fingers bent back in a totally gross way, and I ran up a lot of bills. Better? I saw the doctor last week. I had a cold. I wanted to check it out before coming here. But basically, I haven't spent anything on health care to speak of since then. You get sick, and bam, your spending explodes. So what do you do if you're a health insurer? Find the 10%. Find those who are going to get sick, drop them. Lemon dropping. Identify those who are going to get sick, get rid of them. Shoot them if you can. If you can't do that, find a way to discourage them from going. You've all heard the story of the insurer in Wisconsin who said, we'll sell insurance to anybody. We don't discriminate. All you have to do is come to our office. 5th floor of a walk-up. Cherry picking. Identify the healthy and bring them in. One health insurer in Massachusetts, nice company, nice guys, Tufts Health Plan, says, we do all sorts of things to help keep people be healthy. So we'll give you a discount on your health club, your gym. Now, of course, if you're disabled, you're not going to be using the gym. That's not going to be attractive. If you're 22 years old, fresh out of college, you want to stay in shape, you like interacting with people who like to stay in shape, a gym membership's attractive. There are all sorts of ways like that insurers, and they hire people whose job is to find the things that sick people don't like, do them, find the things that healthy people like, cherry pick, and attract them, do them. And if you don't do that, you're going to go bankrupt. You'll go into the death spiral, which is like being on the Death Star, except without Luke's saber. If you have a plan that attracts sick people because you're nice, your pool becomes more expensive, you raise rates, higher rates, healthy people opt out. That's too expensive for me. I can get a cheaper plan. The more options you have, the more you have to worry about this. The more, if you got 50 different plans, you can really customize it so that the sick people go to that plan and the healthy people go to this plan. And you profit off them all. You add to that, that's most of the problem of U.S. healthcare is the administrative burden. Then there's also the drug prices. I could tell you some other time stories from Italy, where I was last semester, about buying drugs at a fraction of the U.S. prices. It works. CEOs at 6 prominent health insurers and healthcare companies, $198 million in compensation in 2012, including Express Scripts, Ed's old boss, $59 million. I don't mean to pick on these people. I can believe he's a nice guy. She's not. But, And I do wonder about poor Michael McAllister. Humana, $7 million, that's all you can pay him? I'm sure he thinks about that. If I got these numbers, you think he didn't? Anyway, here's one of my favorite headlines. Health insurers making record profits as many postpone care. That's what they want. This was, coming out of the Great Recession, but it's the goal of health insurers in the United States. Reduce access. Single payer will be economical, will save money because it gets rid of all this stuff. Gets rid of all those multiple plans so you don't need so many billing people. Toronto General Hospital has 2 people in its billing office. Mass General, 450. Because They have to work out those 20-page bills for each separate insurance plan. A single payer, we're going to beat up the drug companies. We'll make them give us the rates that they give the Veterans Administration. The Veterans Administration buys drugs basically at Canadian prices, at French prices, at German prices. National savings from a single payer plan. HR 676 is the Improved Medicare for All Act, which I recommend you tell everybody about and, whatever. I estimate $592 billion in savings this year if we had enacted it last year. $220 million from provider offices, reduced billing and insurance activities in hospitals and doctors' offices. $197 by getting rid of the administrative overhead in the insurance companies. $116 million by beating up on the drug companies. From that, we'd have about $400 billion on increased access, utilization by doing away with copays. $110 million from expanded coverage. $90 million. This number is outdated because we're actually doing some of this in the ACA, paying doctors who take Medicaid patients at the Medicare rate instead of a ridiculously low number. I mean, Massachusetts, physicians on Medicaid were being paid at 2/3 the rate of Medicare, and the Medicare rate is itself a bit below what you might get. Okay, until you do that, you can do it in Missouri. You're the show me state. Show us. Beat Vermont. They're kind of dragging their feet a little bit. Give them an incentive to hurry up on their single payer plan. But Missouri, you can do it. You don't need to wait for the United States. You can do it yourself. Have a single payer plan that will take care of a lot of the expenses. You would save $12 billion next year if you enacted single payer this year. $12 billion from provider administration, this is the billing and insurance operations. Sorry, I switched from billions to millions. But you just divide this by 1,000, and you get something comparable to the previous graph. You'd have greater costs of about $4 billion. This number, the utilization, I calculated a little bit differently than I did earlier. This, I think, is actually a better number. It reflects that the last couple of years we've been squeezing access, making it so that when you remove barriers to access, you'll get a bump when people start going to the doctor. Net savings, $8 billion in the first year through elimination of excessive growth in the administrative burden. On coordinating investment, you will be able to save more and more over time. You will bend the cost curve. Remember, the things that have been going up faster are drug prices and administration. If you control those, then you're going to slow the growth of the costs. Again, I've got spreadsheets with lots and lots of numbers. I've tried to, in every case, be conservative. I think the true number here would be better than what's shown. But I'm saying, okay, if we slowed the growth in health spending to the rate of growth in the rest of the OECD, then your spending would grow like this in Missouri compared to this. So after 10 years, so right away you'd have an $8 billion in savings, even while covering everybody and giving you easier access. After 10 years, you would have a saving of $20 billion. Can you think of an economic policy that you could do that would have that sort of savings, that would have that much of an improvement? And it would be fairer. Instead of victimizing the sick when they need to go to the doctor, we would be distributing the burden of health care according to income. Remember, it was a fixed fee and therefore particularly onerous on the poor and the working class. Well, we have an 8% payroll tax on all wages and salaries, and an 8% tax on dividends, interest, rents, and profits. Flat tax. What's his name? Steve Forbes would like it. It's a flat tax. And it would more than cover the costs, and here's the impact. The net for people at the bottom would be an increase in the after-tax, after-healthcare income of 20%. Substituting flat taxes for fixed per capita course. The higher up you go, the benefits drop, but 95% of the population of Missouri would benefit. That is, would have more money in their pockets. What would they do with their more money? They'd buy a boat, and they'd give jobs to people who build boats. The average premium for a worker with health insurance in Missouri in 2012 was $9,000. Average deductible, almost $2,000. This person, somebody who spent the whole deductible, would have $11,000 in cost, not counting co-pays or other things, out of $44,000 in average income for a worker in Missouri, private sector worker. 25% of their salary is going to health care. They would save $7,500. I mean, you know, these people in the Ozarks who were driving by, I mean, $7,500. They work at 3M, that's a really good job. Yeah, a good gain for them. And there'd be 50,000 more jobs of this. In the boats, and also, you're the first state to do it, you're the show me state. Every company in the United States and Canada will look to Missouri and say, hey, maybe that's where we want to locate our next business, our next investment. We can go to Missouri, we can leave Illinois and go to Missouri, save money on health care, not have to deal with the health insurance business. We just kind of like, we can just concentrate on our own business and not have to worry about health care. We can hire workers according to whether they're good workers for us, not have to think about, oh, I don't want to hire that person. You know, her husband has cancer, and that's going to drive up our health insurance premiums. Just concentrate on your business. That's going to make Missouri a very attractive place. And that's going to attract more jobs. And your businesses in Missouri will be able to undersell their competitors in Illinois, in Iowa, in Kansas, because they're not spending as much on health care. Yeah. So you get 50,000 new jobs. The point is you've got to get the profit motive out. You've got to get the insurance companies out. You've got to just concentrate on health care, and business can just concentrate on business, and we'll all be happy. Thank you very much.